Now, the last point I want to make is this method of, do you do it anatomically or do you do it functionally? So everything I've described up until now, people are doing it more anatomically. So they say, hey, I can get rid of the back wall. I can get rid of the four corners of the back wall, the pulmonary veins. I'm going to do what we call a pulmonary vein isolation, whether I freeze it with a cryo balloon, or I use the pulse-filled ablation, or I do it with cauterization, or whether I do it surgically and have a Wolf mini maze, or I have a surgical hybrid ablation to get rid of those four corners, which breaks it up into two procedures, whatever. If you're going to just do those four corners, you're just doing it anatomically. You're saying, hey, whether you're persistent or long-standing persistent or paroxysmal, I'm just going to do this. And hey, if you're paroxysmal and 89%, I get you the result, great. But if you're persistent or long-standing persistent stage and I only get 40, 50% result or 30, 40%, well, it is what it is. And then they'll just load you up with a drug, an antiarrhythmic drug, to try to suppress the rest. Well, that is one way of doing it. I do it a different way. I do it more functionally. So when I go in for an advanced case where the person is in it 60, 70, 80, 90%, or virtually 100%, verging on permanent, then I'm going to see AFib cells all over, on all the walls. So at the beginning, I may do it partly anatomically. I know from years of experience kind of how the atrial fibrillation cells spread. I know they're going to have it on the corners, but that's not going to be enough in those advanced stages to just get rid of that. That doesn't take me very long. And then I'm going to go around the appendage, where I'm going to get rid of cells coming out from that area, not surgically closing it, but cauterizing around it. And then I'm going to do the roof and the floor, roof and then the back wall. And then later on, I'm going to do the floor and then the front wall, anterior wall, and the septum. So I kind of do it generally in order. And as I get rid of these cells, if I'm doing it effectively and making good lesions, not just a bunch of patchy scars, then I can actually get people's AFib to slow and slow, as you know, because AFib is all these dozens upon dozens of sources on multiple walls all firing off. It's so chaotic. I get it to be less and less and less as I do wall by wall. And then actually the AFib, you can see it in the lab, you can see it starts to become less chaotic and become more organized because there's less sources firing off. And then it becomes oftentimes this intermediate rhythm, this atypical atrial flutter. As you're getting rid of the sources of AFib, it organizes into this sort of intermediate rhythm, and then I can actually get it to stop. So my endpoint is not just I do a little bit anatomically, shock the rest back to sleep, and then say, well, let's see what happens, and maybe I need to do 2, 3, 4, 5 ablations on you. No, our goal is to try to, if possible, get the AFib to stop on its own, because that would suggest I'm hitting all the right areas. And whether I achieve that with 3 walls, 4 walls, 5 walls, or 6 walls, I'm going to try to do that. Now, in these very, very advanced stages where the person's virtually permanent, I can't always ablate them into normal rhythm or sinus rhythm. But over the years, I've been able to now do it, when looking at my data, probably 80% of the time. And so when I am able to achieve that, I have a better sense that I'm hitting all the right areas. Now, that doesn't mean that a little bit here, a little bit there can't recover from the procedure, whether I cauterize it or whatever. Yes, a little bit here, a little bit there. Most of the time, if I can really get it to stop, the AFib to stop on its own, not just do a little bit and then shock the rest back to sleep, most of the time I will never see AFib rhythm ever again. I will have hit all the points, sources of AFib, so that it's no longer, I've gotten rid of the AFib. But when I do see a recurrence in that 20% of the time, it's usually a little gap here and a little gap there in the lesions I made on certain walls, where an atypical atrial flutter, that intermediate rhythm, the circular circuit around scar, I may see that, in which case that could be possibly suppressed with a drug, or if I go back in for a touch-up procedure, the 20% of the times that I do that, then just finding those last couple areas can usually get the person all the way back to normal rhythm. And of course, if it's permanent AFib, well, I've had some success doing a very complex lesion set on all 6 walls, where I can pull some people back to being permanent to mostly a normal rhythm. But once it's truly permanent, permanent is permanent, and that's why we call it permanent, because once it's permanent, you really can't get the person back to normal rhythm no matter what you do. And so therefore, mine is more of a functional approach. I actually cauterize until I can get the AFib to slow and become less chaotic and become more organized, because that means there's less sources, and then try to get that completely back to normal rhythm. And then oftentimes I will try to wake up anything more, and my endpoint is usually when I can't wake up anything more. Now, one of the ways you know that somebody is doing it anatomically versus functionally, most people actually do it anatomically. Not a lot of people do it functionally because not a lot of people really do super advanced ablations. But one of the ways you know that is if you are on an antiarrhythmic medication, meaning a drug that we're using to keep things asleep. Remember, those drugs don't get rid of the AFib cells. They just kind of mask them until your AFib gets strong enough and grows enough that it overrides that. If you're on an antiarrhythmic drug and you're, say, breaking through and they say, okay, let's do an ablation, you know that the doctor's doing an anatomic approach when they don't stop your antiarrhythmic medication. So they'll just keep you on that drug, which I guess that makes their results look better. But in me, that's kind of pointless because I want to see where all the AFib cells are. I want to try to get rid of it wall by wall until I see it lessen and lessen and organize and either stop or become an intermediate rhythm around scar that I can then map and cauterize back to normal rhythm to know I pretty much got rid of everything. And once I get that result, I know that if there is anything left over, it's just going to be a little recovery here and there that I could touch up if I needed to, as opposed to, well, I have a recurrence, somebody has a recurrence because they just didn't do enough. Well, people will keep them on the antiarrhythmic drug. And by keeping them on the antiarrhythmic drug, think about it this way. If you had, say, 4 walls worth of sources and you're kept on the drug and it's keeping part of that asleep, so maybe 2 walls worth, then even if I went in there functionally and I only saw stuff on 2 walls and I got rid of it and then you go back to normal rhythm, I may think that I got the result, but really you have more than that. It's just your AFib sources on the other 2 walls are being kept asleep by that drug. And so therefore, once we finish the procedure and then eventually after a couple of months of letting things settle down, I stop that drug, you're gonna have those remaining 2 walls and you're probably gonna still go back into atrial fibrillation and just have a little bit less of it. So that's why I always stop people on those medications before I do my ablation because I actually want to see everything. But if you're just doing it anatomically, and as we already pointed out, that doesn't usually get all of it. It's just doing a little bit what you're prepared to do for that day or that period of time, and then just do more if you need to. Well, then what do they care? They keep you on that drug, they get rid of a little bit, and great. If getting rid of that little bit is enough where the remainder of your AFib is being kept asleep by that drug, then they may feel like, oh, look, I got you the result because you're not having it anymore. But did they really get you the result? They made it a little bit better, but they didn't actually get rid of all of it. So for example, I had a patient a year ago who came to me for a second opinion, and he was breaking through the second strongest drug called Tikosyn. And that drug's a pretty powerful drug. If you use the analogy of the forest fire, I would say that maybe it can suppress 70% of AFib cells on 70% of the walls. So let's say, talking about number of walls, if we said analogy-wise, that it can suppress 4 walls out of the 6 walls worth of AFib cells, or 4 sources, areas of sources, and now he progressed to 75% worth, or 4.5 walls, and now he's breaking through a little bit. Well, they went ahead and did a simple 1-wall ablation, or just the corners of that first wall where the pulmonary veins insert, as I mentioned, and kept him on that drug, and now he didn't have any more breakthrough. But did they really get rid of the AFib? No, they just got rid of a little bit. They got rid of 1 wall's worth, and he had 4.5 walls. They just made him to 3.5 walls worth of AFib sources or triggers. And then they used the drug, which can suppress like 4 walls worth, to suppress the rest. It's like saying you have a 75% forest fire, the drug is able to suppress 70%, so you're having 5% breakthrough, and then they get rid of 10 or 20%, and now you're at 50 to 60%. And they keep you on the drug to keep that suppressed. If he wasn't on that drug, he'd probably still be in at 50% or more of the time. But on that drug, he had nothing for a year, maybe 1 to 2 years, and then he grew back from that 50% back up to 70, 75%, and he was breaking through the drug again. And then he comes to me and says, well, why did it only last a year? I said, well, because they didn't really get rid of all of it. He says, what do you mean they didn't get rid of all of it? I didn't have any symptoms or any AFib for a year and a half. I said, well, yeah, because it took you that much time to grow from 50, 60% walls back up to 70, 75% walls. If they had really gotten you down to 0 or 5 or 10% or mostly 0, they could have stopped that drug, the second strongest drug, and you'd have 5 or 10% or none. Or they could have stopped it, you had 5 or 10% AFib, and then they put you on a weaker drug that could suppress 10% and have you work your way back up to that level. But instead, they just got rid of a little bit and then kept you on the second strongest drug that you were breaking through to keep the rest masked or asleep. Now, that may look like a success, but just know it for what it is. It's just a partial success. Anytime somebody goes in, whether they're very skilled and they are able to do multiple walls if you need it, or they're not very skilled and they just do one wall. Or whether you have it done surgically one wall or surgically, multiple walls, depending on which surgical procedure you do, people are getting rid of these AFib cells and sources. So that in a sense, they are turning the clock back to an earlier stage of your forest fire. But whether they actually turn it all the way back down to zero, or they just turn it back a little bit and then mask the rest with a drug, that's kind of the difference. So just realize what's actually happening and know for yourself. So if you are going to somebody that's not going to stop your antiarrhythmic drug that you're breaking through, then just know, ask them, what are you doing? You're just probably just doing it anatomically. And they may say, well, I'm going to get rid of that first wall. And then if you shock the rest back to sleep, and then if you need more, I'll go back in multiple times to do more. Great. If that's the best that can be done in that area for your stage, then I guess you have to do that. But if you can go do more, whether it be surgical, somebody doing more advanced ablations, then try to go and do more. If you're at an early stage where that's enough, then it doesn't really matter. I don't care who you go to. They're all going to get a good result, 80, 90% success rate, because small is small, easy is easy, and a small forest fire just isn't that hard. So remember, you need to look at it in terms of what's being done, and then what's being done, what energy source are they using? And yes, there are some advantages and disadvantages to different energy sources, or whether you do it surgically or not. The different energy sources, freezing is definitely safer than cauterization. But remember, those balloons can't really reach more than, they're really made just to do the four corners, because they fit nicely into those four corners where those pulmonary veins insert into the back wall. Some competent electrophysiologists have experimented with dragging it across the roof and the back wall to get maybe 2 more walls worth out of the 6. But you can do that with cauterization catheter, a little bit more precise, but that way they don't have to bring it back for another procedure. So I applaud them for that. But it's really not meant to make lesions on the other walls. It really doesn't fit. The pulse field ablation is a great energy source with minimal risk of complications and is quick, but in its current iteration, it only really is made to do the corners of that back wall, the pulmonary veins. And that's really what people are using it for. And until those of us who do more advanced ablations, try to experiment with it and try to see if we can use it in other ways, and they keep improving the catheter over time, one day it may get to the point where we can use it for other things, but it's really not there yet, at least here in 2024, where it's first introduced. Surgically, yes, if you can go somewhere and get a full Cox-Maze 3 procedure that makes lesions on the back wall corners, the pulmonary veins, and the back wall, and the roof of the back wall, and the floor of that left upper chamber, and the front wall, and the septum, and the lateral wall around the appendage, and also on the floor and side wall of the right atrial appendage, well then, yeah, I don't care what stage of AFib you're in, you're probably gonna get a great 80, 90% success rate, but that's open heart surgery where it literally, they're cracking your chest bone open, they're having your heart actually stopped so they can make burns and freezes on your heart. And that's only done at a handful of centers. If you're just going to have somebody do a mini maze or a hybrid, or a surgeon who's doing your bypass or a valve replacement, and they say, oh yeah, I did a Cox-Maze, they're referring to a simplistic Cox-Maze where they just made lesions around the 4 corners of pulmonary veins. It's something we can all do on the inside, even if you're not that skilled, in an hour and a half or less. Yeah, that's all they're doing. But if you can have a more advanced ablation set and you need it, then go for that. If you don't need it, great. I don't care where you go. If you need it and it's not being offered in your area, well, then you may want to do your homework or just accept that. Maybe you may have to have multiple procedures. And this is kind of the downside of it, because having done this for over 20 years and getting lots of second opinions over the years, I mean, I don't care what people do. I just want people to have that information and do what they think is right for them and not be bullied into procedures. But if you're going to do a procedure, I hope that the person's competent and doing a good job. But a lot of times the person's had 3, 4 ablations and they say it as if, you haven't had 3 ablations, as if, well, I must be permanent because look, I had 3 ablations, as if all the ablations are the same, as if they're achieving the same result. And a lot of times I'll actually look at the procedure reports and say, well, this person tried to do the back wall, the 4 corners of the back wall where the pulmonaries are with cauterization catheter, and they didn't even do a very good job. And then the second person you went to froze it, so they probably got it. And then the third person either did that a third time, which is not very helpful, or they kind of touched that up and then did a little bit on the roof. Well, that might be 3 ablations, and you look at what was done, it amounted to 1 wall or 1.5 walls, or maybe 2 walls. And maybe they have 4 walls that need to be done, and I don't care that they had 3 ablations or 5 ablations. If the persons who are doing it are just doing simple stuff, then to me, it may amount to like, well, they could have all been done in 1 procedure, and maybe more could have been done in 1 procedure. So it's not just, I've had 3 ablations, but that's the problem. because people just do kind of what's easy and they just do the back wall, and not that many people do more, because to do more, you'll get paid less. And also to learn how to do that, you're gonna make more patchy scar initially, and then that could set you up for a lot of these intermediate atypical atrial flutter rhythms. And so people just kind of do whatever they can do, which is oftentimes not enough for the patient. And then people end up having 2, 3, 4 procedures, and then they get kind of procedured out, where they go, oh, I've had 3 procedures. And I say, well, you know, honestly, your AFib isn't yet permanent. It's still a ways away from that. I just think you need a more advanced lesion set. They go, no, I don't want to do any more. You know, they've already tried 3 times, and I'm just not going to go for it again. So that's kind of disappointing. If somebody had done a more advanced lesion set competently to begin with, and they could have saved that person multiple procedures. So just think about it that way, in terms of, yes, how you do it, the energy source or surgical or from the inside, there are pros and cons. You know, doing it from the inside is safer, and the surgical is a lot more involved, a lot bigger recuperation, but has the advantage of making more deeper lesions, more complete lesions for these more advanced cases. But doing it from the inside, some of us can do that from the inside and have you recuperate a lot easier. But once again, it's about not just how you do it, but what strategy you're employing. What's your stage? How many walls are involved? Are you paroxysmal, persistent, long-standing, persistent, or close to permanent? How much do you think might need to be done? And then what's somebody going to do? Are they going to actually stop your entry of the drug and try to see everything and try to go after everything? Or are they just going to do it anatomically on what they can do that multiple times and keep you on the drug? And if you have less on the drug, then they call that a success, which I guess it is sort of a success. So what is somebody planning to do? What stage are you in? What are they planning to do? And then how are they planning to do it, whether it be from the inside surgically or what energy source? I would go in that order.